I'm going to build on some of the concepts that Dr. Katz presented and maybe give you maybe a little bit more of an optimistic view of how we can use risk factor assessment to intervene on patients to improve outcomes and use cardiac surgery really as the model here. So you've seen some data, but let me just reiterate that the incidence of acute kidney injury, depending upon the definition and stage, is certainly very common with cardiac surgery patients. Lower stages, risk for stage 1, anywhere from 17 to up to 50%. Later stages, 4 to 9%. And depending upon the study, the need for renal replacement has really remained fairly consistent over the last several decades at about 2 to 6%. The highest risk patients, as you've heard from Dr. Katz, those requiring ECMO, they nearly have about an 80% incidence of acute kidney injury, and now it's pretty standard to see your dialysis machine hooked up to the ECMO circuit. In the pediatric population, data also shows that outcomes and acute kidney injury is relatively common. Now, the implications of acute kidney injury, you heard this, I think, from Dr. Kellum yesterday, but acute kidney injury is a very morbid condition. I think the last 2 points in this slide are really the most important to me. For those who develop acute kidney injury post-cardiac surgery, who've gone through a large life-changing procedure, if you need dialysis post-operatively, 2/3 of those patients stay on dialysis permanently, and nearly 90% of those patients are dead within a year. So the long-term outcomes of acute kidney injury in this patient population are quite significant, which really makes prevention very, very critical here. So we've learned a lot about the pathogenesis of acute kidney injury associated with cardiac surgery, and this has been an interest of ours for numerous years. But the bottom line is there are so many different factors that are operative, and they're operative at very different times, and each individual factor's overall contribution to the end result of injury is really not well understood. So there's exogenous nephrotoxins, medications that we give to patients. There's endogenous nephrotoxins, probably the most important being free catalytic iron. There's ischemia of reperfusion injury, inflammation, embolization, the hemodynamic alterations that Dr. Katz alluded to, neurohormonal activation, oxidative stress, and all of these factors are operative and interact with one another to give you ultimately the outcome of acute kidney injury. And when we think about risk assessment, this comes from the KDIGO work group, you have the patient has various susceptibilities, and then they have the exposure. And that susceptibility and the exposure ultimately gives us the risk of developing acute kidney injury. So we have some mitigation strategies that certainly we can use in all patients. Minimizing nephrotoxins, obviously ensuring optimal volume status, ensuring optimal perfusion pressure, avoiding hyperglycemia, and early and appropriate nephrology consultation. And our goal is really to use the pathogenic situation that I've described just a second ago to define situational risks. Of those situational risks, to define which risk factors can be intervened upon, to use those modifiable risk factors essentially to develop a bundle of preventative measures. So let me just cover a little bit of recent data on some of the nephrotoxins, some controversies in this area, just to give you an overview of some of the more recent data. So certainly these patients are quite ill. Oftentimes they come in with emergent procedures. They may have been exposed to multiple nephrotoxic agents, including radiocontrast. In the radiocontrast era, certainly there's data that now suggests that the use of IV radiocontrast agents in a patient who's going to bypass surgery is associated with an increased risk. And ideally, there should be some delay between that exposure and the surgical. The use of low-dose aspirin has been initially somewhat controversial in this area, but I think the data now supports the fact that it probably has a protective effect on major both cardiovascular outcomes as well as data on renal dysfunction postoperatively. But there's some controversies in this area. What about the common question, do I stop the ACE inhibitor preoperatively? Do I continue it in my patients? And I think there's studies that really show you data across the spectrum. In the perioperative, and postoperative period, there's studies showing harm, studies showing no benefit, and there's studies showing some benefits. Probably the best recent meta-analysis, about almost 2 years ago now, showed that patients taking RAS inhibitors preoperatively had an increased rate of odds ratio about 1.17, and mortality was higher in those patients who were taking it preoperatively, and the drug was continued prior to surgery. However, it's important to realize that when you look at these AKI events, they tend to be associated with more functional rises in creatinine and have not been associated, in most cases, with rises in associated biomarkers. So there is actually a larger randomized controlled trial that's looking at this area and to see what the role of either continuing or discontinuing these drugs preoperatively needs to be. Statins also have been controversial in this area. Many surgeons a few years ago took the adoption that statins would be started preoperatively in many centers. I think it's become less clear with randomized controlled trials, especially in the sepsis-associated ARDS area, that maybe statins may be associated with even a significant increase in acute kidney injury. So in the statin risk factor idea, I think most centers now follow the recommendation that if a patient's on it, you just continue it through the operative period and post-operative period, but starting it for really renal protection is probably of very little to no benefit. Now, another area that I think has really gotten a lot of attention recently is the idea of mechanical blood trauma. Certainly this is caused by the centrifugal blood pumps, the oxygenator turbulence, cardiotomy suctioning, cell saver use, and it leads to a significant amount of hemolysis with generation of free iron and hemoglobin. And when you look at some of the studies, this may be one of the largest contributors, I think, to acute kidney injury in this setting. So that free hemoglobin is reacted upon by hydrogen peroxide and superoxide and leads to free catalytic iron. And that can be bound by ferritin and essentially detoxified, or it can go on to form hydroxyl formation and tissue damage. Interestingly, there's a whole host of data that shows that actually patients with higher preoperative ferritin levels have lower risks of acute kidney injury. But most recently in the study in Kidney International this year, Leaf and Cole workers measured free catalytic iron levels in patients post-bypass surgery, and they noticed that those patients with the highest levels of free catalytic iron had almost a 7-fold increase in acute kidney injury. Now, there are numerous studies looking at detoxifying free catalytic iron and mechanisms to do this, but this may be actually a particular target of interest in this setting. So just to summarize in terms of pathogenesis and thinking about risk factors, there's certainly preoperative factors, there's intraoperative factors, and postoperative factors. I want to just take a second to think a little bit about some of the intraoperative factors that Dr. Cass mentioned and maybe some things that we can intervene on. So first, we have some risk scoring systems that are out there. We have the STS risk calculator. I just want to make a mention that these risk calculators are somewhat problematic in that they have pretty good negative predictive value, but their ability to have positive predictive value is relatively poor. They can be useful in at least guiding some informed consent process, and that's how we use them at our center. What about intraoperative and postoperative care? You heard from Dr. Cass the issues around cardiopulmonary bypass and some of the risk factors. Certainly, combined valve and bypass procedures have much higher risks. Longer bypass times are associated with risk. The perfusion pressure issue is quite interestingly, and I'm going to show you in a second our approach, but I agree with Dr. Bellomo's point. We actually target higher perfusion pressures if we know that the patient has had chronic hypertension, and with the idea that they probably have less autoregulatory capacity, especially also in diabetic patients. We typically, although the data I would say is poor in this area, do target higher perfusion pressures for these patients. The hematocrit during bypass is also, I think, critically important. You heard a little bit about this, about the hemodilution that occurs, and there's a clear relationship between the lowest hematocrit that's achieved during bypass surgery and the risk for acute kidney injury, with a very strong relationship. However, transfusion of packed red cells has, in fact, worsened the outcome. So there may be an optimal hemoglobin. Our review of the literature suggests we feel that it's about 8 to 8.5 to target that balances the various risks and benefits. But this is an area that really needs more clarification, but is critically important in treating these patients appropriately. You heard also, and you saw from Dr. Cass, the number one risk factor for acute kidney injury in many studies is perioperative transfusion of red cells. And the general recommendation, I think, from most centers, given this risk, is to use extreme caution in transfusing patients. And you want to make decisions based upon clear clinical need, i.e. increasing oxygen delivery and likely guided by some measurement that's helping you guide that decision, because clearly post-operative transfusions are associated in some studies with a 20-fold or higher risk of acute kidney injury post-operatively. So what do we know about preventative techniques, and how can we create this bundle knowing the risk factors? So there's certain things that we stress. So glucose management post-operatively. So lots of data in this area, some of which is controversial, some of which has been refuted, but we certainly target moderate controls of blood glucose, and I'll show you our data in a second. We generally target levels between 126 and 179. Preoperatively, maybe a little bit lower, but that's generally our targets. We've developed a system that's called the Glucomander. This basically is a real-time looping system that's very accurate in giving you IV insulin doses, and essentially is an insulin clamp technique that's taken from the lab to allow us really to target very, very specific glucose levels. It's quite accurate in maintaining our glucose levels in the ICU. And here's sort of some glycemic control results from our center, looking at major complications, showing the middle group here where we have moderate glycemic control, showing better outcomes as compared to either strict or more liberal control. Also, the new kid on the block, and I think Dr. Kellum's going to talk about this tomorrow, is the issue of prevention using remote ischemic preconditioning. Last year, there was a recent meta-analysis of 11 trials showing that there was some possible benefit, but we just had the JAMA paper, and I'm sure Dr. Kellum's probably going to talk about this in much more detail, where patients were enrolled. That's not 24. I think it was 240 patients. High-risk patients, they were randomized either to the remote ischemic preconditioning using a blood pressure cuff with 3 cycles of blood pressure compression of the to cause limb ischemia. The primary outcome was AKI within 72 hours, and they showed fairly significant results of an absolute risk reduction of about 15% in the group that got remote ischemic preconditioning. Renal replacement therapy was also reduced by 10%, reduced ICU length of stay. And they also showed that this was attenuated the release of biomarkers, again, showing a proof of concept that remote ischemic preconditioning may be a very simple technique that we can use to help prevent acute kidney injury. There's another study from London that I think will be presented in this fall, and we'll see whether that's concordant with this study as well. So drugs, you've heard about this yesterday. There are no drugs to prevent AKI. You could argue maybe fluids for contrast nephropathy, but otherwise we have no pharmacotherapy right now. So based upon what I've told you, we've created a bundle at our center. We had a group of nephrologists, anesthesiologists, and cardiac surgeons who came together somewhat begrudgingly. We identified champions in each area that would be the leads for this area. We meet actually weekly. We have pretty robust data capture with statisticians looking at every event. We actually meet after every event to do a root cause analysis to see what we can do better. And we go back and revise our protocol relatively regularly. So basically, strategies as part of our bundle is nothing really, not rocket science. So we avoid nephrotoxins. And what we found actually, when we looked at this, it was surprisingly how poor, before we enacted this protocol, we had done before. So it's a simple strategy, but it really wasn't always adhered to. The perioperative use of nephrotoxins like NSAIDs, inappropriate antibiotics, and IV contrast were essentially avoided. We tried to delay cardiac surgery at least 48 hours after IV contrast if possible. And we developed computer EMR-based alerts that really showed if there were small changes in serum creatinine prior to the cardiac surgery, that would prompt at least a discussion between the anesthesiologist, nephrologist, and the cardiac surgeon about whether we should go ahead with that procedure rather than wait. So we delay surgery 24 to 48 hours after IV contrast. In our center, we do hold the RAS inhibitors post-operatively and preoperatively until the patient is stable. We optimize glucose control and think this is quite important for outcomes. For any patient who has stage 3 chronic kidney injury and certainly has a scheduled procedure, they see a nephrologist preoperatively to look at risk factors, stratification, and modification. Intraoperatively, We really work with our surgeons, and they've been very good at minimizing bypass time. Sometime at a training institution, which we are, the cardiac surgery fellows are not quite happy about this, but really we try to minimize bypass time as much as possible. Red cell transfusions are strictly avoided unless we have clear indications, and we really aim for higher blood pressure and perfusion targets in patients with chronic hypertension, especially if they've had poorly controlled hypertension preoperatively. Postoperatively, we continue to target moderate glycemic control. We do hemodynamic monitoring, monitored by some goal-directed therapy principles, and I'll touch on this in a second. So what we essentially do is we try to avoid giving fluids indiscriminately, and I'll show you some of the techniques that we use. But essentially, we've gone from our ICU very commonly discharging patients with 10 liters or more gain in weight from their preoperative situation to essentially almost every patient leaving the ICU no more than 1 or 2 kilos, but usually at their preoperative weight. We transfuse red cells again begrudgingly, and diuretics are held off unless they have specific medical indications. This, I would tell you, is a very difficult, probably the most difficult thing, was to take the diuretics out of the hands of the cardiac surgeons. The nurses here were our friends. They basically dove on those grenades and prevented that without at least a discussion about what the goal would be. So just to talk a little bit about our fluid management for just a second, we take the approach that we want to really look at fluid responsiveness. I'm not going to spend much time on this, just in the sake of time here, but we recognize, and I think everybody in this room is well versed in the fact that preload does not predict fluid responsiveness. So a fluid non-responder, someone who doesn't change their hemodynamics, could be someone with high venous compliance, it may be someone with poor ventricular function, it may be someone who's third-spacing fluids. And our measures of cardiac preload are very poor at doing this. And in essence, what that led to is patients getting indiscriminate, huge amounts of fluids in our cardiac ICUs. So what we've tried to do is discriminate as much as possible those patients who will increase their stroke volume in response to fluid therapy and use fluids in only those patients who clearly demonstrate a response. I will tell you we're not 100% successful in doing this, but we've really probably used this in about 70% of cases when fluid boluses or fluid therapy is given. There has to be some measure of fluid responsiveness. This is our technique. We use the Masimo device, which is a Pleth variability index. It basically uses dynamic changes in the peak and the amplitude of the pulse oximeter wave to essentially measure volume changes as opposed to pressure changes. The measure actually shows pretty good correlation to pulse pressure variation, and we find that it can be useful. It has some caveats on it. It's not particularly good if patients are on high-dose pressors. Here's the idea, is that there's a huge amount of variability in the signal in patients before volume expansion. After volume expansion in the second curve, you can see that variability goes away. If the Pleth variability index is very low, it tends to predict that the patient will not respond to fluids. In our hands, if you have a variability index of greater than 14%, it's predictive of fluid responsiveness with a sensitivity of about 80%. So our algorithm, patients with low blood pressure or poor perfusion, we tend to measure this Pleth variability index. If it's greater than 14%, we give fluids. We recheck that variability index. If it's less than 10 to 14%, we think about taking a bedside echo, looking at SpO2, or thinking about inotrope therapy or other methods. So how does this work? So I wrote here still tabulating results. That's not exactly true. So the results are that prior to doing this, we had a renal replacement therapy rate that ran between 4 to 6% in our units. After we've instituted this, the renal replacement rate is about 1%. Length of stay is down about half a day. The problem is that we've changed lots of other things besides this bundle that's occurred at the same time that make results and make me a little bit hesitant to give you results. Things such as new cardiac surgeons coming on board, different procedures, different techniques that have occurred at the same time interval make conclusions, I think, a little bit difficult to come up with here. What we're hoping to do, and we're submitting, we have patient-centered outcome research grants in the United States that look at trials like this to randomize different centers to different aspects of this bundle, to look at very simple things that we can do at the bedside to improve outcomes. So just to summarize, I think you've heard that acute kidney injury in any setting, but as well as sepsis and cardiac surgery is a highly morbid event. It's associated with significant mortality. The mechanisms of injury are extremely complex, and I don't think we completely understand them. They hamper effective therapies. So given that we don't have a good therapy, we have a highly morbid event. Preventive therapies, preventive approaches are really absolutely critical. They hold promise. They require further study. But I think these preventative bundles will really be some of the ways that things will go in the future, where we think about more global, systematic approaches that require collaboration from all specialists looking at various aspects of the care of the patient. So I'll stop there. Apologize for my hoarse voice. Try to get us back on time as well. So thank you very much for your attention.